Bismillah ar-Rahman ar-Rahim. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation CME online meetings. Wednesday, 12th of October. Today is specialized for Zagazig University. We have two major eminent professors from Zagazig University. One great speaker and one great moderator. Our moderator today is Professor Yasser Hindi, Professor of Nephrology and Internal Medicine in Zagazig University, and the head of Sharqiya Union of Nephrologists. And our speaker is our colleague in ESNT board, Professor Amir Elokely, Professor of Nephrology and Internal Medicine, Zagazig University, and he'll catch today an important, very important topic about electrolyte disturbances. We all used to deal with this important hot topic everyday practice in a traditional way. Is there any new drugs, any new methods, or something like this? This we will all expect to hear today. I will leave the floor to Professor Yasser, welcome him, to lead this meeting and to enjoy the lecture and the following discussion. Please, Professor Yasser. Please, Professor Yasser, unmute yourself.
دكتور ياسر حضرتك معانا؟
Please, Professor Yasser.
Okay. Good night, everyone. Today we shall start one of the Egyptian Society of Nephrology and Transplantation Continuous Medical Education, Shaisha Kidney Academy, under supervision of the Professor Yasser Abdelhamid, the coordinator and the manager of this program. And I want to thank my dear colleague Rami Abubakar for his continuous and uneffortless behavior. And I will start to introduce my colleague Amir to tell us about the electrolyte disorder beyond traditional control, mainly on the management and new drug on hyperkalemia and hyponatremia. Please, Dr. Amir.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the Egyptian Society of Nephrology and my colleague Professor Yasser Abdelhamid for his effort in continuous medical education. The title of my presentation today will be Electrolyte Disorders Beyond Traditional Control. When I start the preparation of my presentation, I found that there is a lot of new drugs in different electrolyte disorders, and it will take long time to go through these new medications. So today I will stress in two important abnormality in the electrolyte we usually got in our practice. The first one will be hyperkalemia, and the second one will be hyponatremia, and the new drug used in the treatment of this quite common electrolyte disorder. First of all, starting by hyperkalemia, as we see, potassium excretion usually mainly through the kidney, and through our kidney practice or the daily kidney practice, we usually got a lot of patients presented with hyperkalemia, either from the deterioration in the kidney function or from the multiple drug used in the treatment of the complication of reduction of the estimated or reduction of the GFR. A lot of drug may lead to hyperkalemia, including angiotensin converting enzyme inhibitor, ARBs, aldosterone receptor blocker, and sometimes sodium channel blockers, and some other drugs which may lead to impaired release of renin, like non-steroidal anti-inflammatory drug cyclosporin and tacrolimus, which is quite commonly used in managing patients with chronic kidney disorders. First of all, the aim of our management or the management goal, either we got a patient with acute hyperkalemia or we got a patient with chronic hyperkalemia. Regarding the goal of management of patient with acute hyperkalemia, usually through prevention of potentially life-threatening cardiac conduction and neuromuscular disorders. The other aim is to reduce serum potassium through shift of the potassium into the cell, or elimination of excess potassium, or the final way is resolving the underlying disturbance. And I think we are familiar with most of the drug used in treatment of hyperkalemia. What about the goal for chronic hyperkalemia management? Either prevention of the development of recurrence of hyperkalemia, correction of the underlying defect, and finally increase potassium excretion, either through diuretic treatment or potassium binders. What about the old potassium binders we are using for a long time? We will start by sodium polystyrene sulfonate. Mechanism of action, cation exchange reason, usually exchange sodium for potassium. We are all familiar with the dose from 15 gram to 60 gram, and in patients with chronic kidney disease, half of the dose, and the side effect also including GIT upsets, including nausea, vomiting, anorexia, constipation, and sometimes fecal infections, GI ulceration or necrosis leading to intestinal perforation has been reported in some patients. So, by having a look on the SPS or sodium polystyrene sulfonate, is an old drug approved in 1958 before well-controlled study were required and indicated for treatment of hyperkalemia. This is the first point. The second point, there is no convincing evidence that SPS increase fecal potassium loss in experimental animal or human, and no evidence that adding sorbitol to the resin increase its effectiveness. And also there is a concern that SPS may not be effective without osmotically active amount of sorbitol. That is why we are looking for new medications to control hyperkalemia. We will have a look on this study published in the Clinical Journal American Society of Nephrology in the year 2015, and it was a randomized clinical trial of SPS for the treatment of mild hyperkalemia and CKD. And as we see on the diagram on the left side, the baseline serum potassium, and with final follow-up, there is reduction in the serum potassium from 5.03 to around 4. But what about the percentage of patients reaching normokalemia in the final follow-up with this drug? As we see, it is more with SPS, but the difference between SPS and placebo was not statistically significant. And this study, as I said before, published in the year 2015. So these are the new drugs, or we will go through the new drugs which was released by the year maybe 2022 in Egypt, and this drug is not released so far in Egypt. I will start by Batirumir, going through the chemical structures, dosing, and the study which was published regarding the use of Batirumir in management of hyperkalemia in patients with chronic kidney disease, and some study in patients under hemodialysis. First of all, the biochemistry of this drug is orally administered drug, non-absorbed, calcium-based potassium binding polymer, indicated for treatment of hyperkalemia. But the most important point, it is not an emergency treatment for life-threatening hyperkalemia. Designed to be fully ionized at the physiological pH of the colon, and the mechanism of action, exchange calcium for potassium in the colon. What about drug-drug interaction? It should be taken 3 hours apart from other oral medication. So it is non-absorbed potassium binding polymer, binding potassium in the colon, and act as a sink to increase colonic potassium excretion. This is the main mechanism of actions of Batyromore, or in trade name, I think Falsata is the trade name of Batyromere. What about Batyromere in patient with kidney disease and hyperkalemia receiving RAS inhibitors? And this is the first study, obal hyperkalemia, published in New England Journal of Medicine 2015. And the patient with chronic kidney disease on RAS inhibitors with hyperkalemia at the baseline. The level of potassium was from 5.1 to less than 6.5. And they classified into 2 phases. Phase 1, treatment phase, and it was treatment with Batyromere for 4 weeks with 2 doses. The first one was 4.2 grams twice daily of the serum potassium from 5.1 to 5.5, and 8.4 grams twice daily if potassium from 5.5 to less than 6.5. And phase 2, withdrawal phase. Eligible patients, the number of patients was around 100 patients. Were those with baseline potassium of 5.5 to 6.4. In whom the potassium level decreased to 3.8 to 5 and raised again with the stopping of Batyromere. Randomized to continuous Batyromere or switch to placebo for 4 weeks. What about the result? As we see, the main serum potassium in all subjects or group 1 and group 2, as we see, start to be markedly reduced by day 3 from 5.8 to around 5 and less than 5. And by week 1, week 2, week 3, and week 4, there is marked reduction in the serum potassium level in different group of the study. And the table beside this diagram usually illustrates the difference and the reduction in serum potassium. With a small dose, 4.2, the reduction was around 0.65 milli equivalent, and in group 2, the reduction was around 1.23 milli equivalent. Phase 2 trial and phase 2 result, as we see, marked reduction in the serum potassium level with the use of Batyromere. During phase 2 study, as we see, there is reduction in the potassium through the whole phases of the study, including the first phase from week 1 to 4 and week 5 to 8. As we see, there is marked reduction in the serum potassium level with Batyromere if compared with placebo. What about the primary efficacy endpoint in the randomized withdrawal phase according to subgroups? During this study, they classified the patient according to the underlying problems, including patient with type 2 diabetes, patient with heart failure, old age patient. As we see, there is a reduction in the serum potassium with the use of Batyromere, and the outcome was favorable with the use of Batyromere. What about the adverse events during the initial treatment phase and through the safety follow-up period of that phase? As we see, the most common side effects are GIT side effects, including constipation, diarrhea, hypomagnesemia, nausea, anemia. And during the follow-up period, the GIT effect start to be decreased, and the common side effect was headache, sometimes supraventricular extrastoles, followed by other GIT side effect as constipation and diarrhea. Another study, Amethyst diabetic nephropathy trial. It was an extended trials for about 52 weeks and published in the journal American Medical Association in the year 2015. And as we see, the reduction in the serum potassium level with Batyromere start with day 1 and continue through the whole duration of the study, and with the stopping of the drug by the year 52, by the week 52, the serum level of potassium in mild and moderate cases of hyperkalemia start to rise again. This is another study. The interesting study that patiromer decreased serum potassium and phosphate level in patients on hemodialysis. Actually, the number of patients on this study published in the American Journal of Nephrology in the year 2016 was very small number of patients. It was about 6 patients, and they admit this 6 patients in the hospital for the 2 weeks duration of the study. And what did they do? They admit the patient to the hospital and they do hemodialysis session, as we see every other day for the first week, and they measure potassium after the dialysis sessions in the first week without patiromer, and in the second week with the use of patiromer. As we see, without the use of patiromer, the serum potassium level was in the range of 5.5. And with the use of patiromer, the serum potassium level go down to around 5 millimole, as we see in this diagram. The interesting finding in this study also, they measured the stool potassium and phosphorus level, and they found that with the use of patiromer, there is increase in the excretion of potassium and phosphate level in the patient using this drug. What about the result? As we see, there is marked reduction in the serum potassium with the use of patiromer in the week of treatment if compared with the pre-treatment week. This is the first point. Serum potassium level, as we see also, there is a reduction in the serum potassium level with patiromer treatment, as shown in this diagram. So, regarding the safety and the tolerability profile of patiromer, most adverse events reported from trial were GIT, as we said before. Most frequently reported GIT related adverse events were generally mild to moderate in nature, did not appear to be dose related, generally resolved spontaneously or with treatment, and none was reported as serious side effect. Hypomagnesemia was reported. Hypokalemia was reported in some patients. That's why we should check serum potassium level during our treatment with patiromer. And interaction, we should use it 3 hours before other oral medication. Regarding the newcomers or the other drug, which released in Egypt by the start of 2022, sodium zirconium cyclosilicate by the name of, or trade name of, Elokely. Inorganic crystalline potassium binder, orally administered, sodium-based potassium selective cation exchanger, primary active in the gastrointestinal tract. The good point is that it is insoluble, highly stable, 9.3 more potassium binding capacity than sodium polystyrene sulfonate, trioxalate, and more than 125 more selective for potassium than sodium polystyrene sulfonate. Going through the study done on Elokely or sodium zirconium cyclosilicate, the first one was harmonized trial, multi-center randomized double-blind placebo-controlled trial. Number of patients was 237. Evaluating sodium zirconium cyclosilicate 3 times daily in an initial 48-hour open label phase. This is regarding the use of Elokely in acute situation or acute hyperkalemia. And the follow-up, patient achieving normokalemia were randomized to once daily treatment for 28 days with sodium zirconium cyclosilicate, either 5 gram, 10 gram, 15 gram compared with placebo. It includes different groups of patients susceptible to hyperkalemia, patient with congestive heart failure, patient under RAF therapy, and patient with diabetes. What about serum potassium level during the 48 hours by demographic? As we see, markedly reduced in all group of patients and different subcategory of patient, including patient with CKD, patient taking RAS inhibitors. The second point, serum potassium level during the randomized phase from day 8 to 29 according to the study group. And as we see, with different doses of Lokelma, there is reduction in the serum potassium level as we see in this diagram. What about the side effect? As we said before, most probably gastrointestinal side effect. Hypokalemia is quite common, and we should measure serum potassium during the treatment with this agent. Another study published in the New England Journal of Medicine, multi-center, double-blind, phase 3 trial. The number of patients was about 3 times the previous study, around 750 patients with hyperkalemia. Phase 1 study, patient randomly assigned to receive 3 times daily treatment for 48 hours with sodium zirconium cyclosilicate, different doses. Very small dose, 1.25 gram up to 10 gram. And phase 2, patient achieving normokalemia, randomly assigned to once daily treatment from day 3 to day 11 with sodium zirconium cyclosilicate, small doses reaching up to 10 gram compared with a placebo. And as we see, with the start of treatment with this drug, there is marked reduction in the serum potassium level, as we see in the first part of the diagram on the left-hand side. And from day 3 to day 11, there is marked reduction in the serum potassium level with the stopping of treatment or off of the drug or stopping the drug. The serum potassium level start to rise again. And these are the common adverse events. As we see, gastrointestinal disorders, sometimes some sort of arrhythmia. During the maintenance phase, also gastrointestinal disorders and cardiac disorders. This is a quite important study, dialysis study. The first randomized placebo-controlled trial to evaluate the efficacy and safety of potassium binder in the treatment of hyperkalemia in hemodialysis patients. And the rationale for this study was hyperkalemia is quite common in patients with CKD, even they reach in the stage. Despite adequate hemodialysis, 30 to 50% of patients have hyperkalemia. And usually hyperkalemia prevalent, particularly after the long interdialytic interval. Pre-dialysis hyperkalemia is associated with increased all-cause mortality and cardiovascular mortality. Arrhythmia, cardiac arrest account for 40% of deaths in patients on chronic hemodialysis. Higher mortality rates are observed after long interdialytic interval. And hyperkalemia independently associated with greater short-term risk of hospitalization and emergency department visit with greater hospital cost. And data on how to optimally manage hyperkalemia in dialysis patient has been limited up to date. The study design was 2 arms. The first arm using sodium zirconium cyclosilicate compared with placebo, and the dose was 5 gram once daily on non-dialysis days. And when the patient start to get serum potassium with the level, continue with the same dose, either 5 gram, and may be titrated reaching up to 15 gram. And the duration of the study was about 8 weeks, and post-treatment follow-up for about 2 weeks. The primary efficacy endpoint, as we see, marked reduction in the serum potassium level with Lokelma. More patients receiving Lokelma had serum potassium level of 3.5 to 5.5 during more than 3 of the 4 hemodialysis sessions after the long interdialytic interval compared with placebo. Pre-dialysis and post-dialysis main serum potassium level were comparable between the groups at the baseline, and it was low in the treatment group if compared with placebo. In summary, the study reached the primary endpoint by lowering serum potassium level. There was no difference between sodium zirconium cyclosilicate and placebo in interdialytic weight gain, a marker of sodium and fluid retention. And Lokelma was well tolerated, more adverse events, with most adverse events mild to moderate in intensity. The adverse event profile between treatment group were similar, including GI adverse events and hyperkalemia. Regarding the safety and the tolerability profile of sodium zirconium cyclosilicate, the common side effects were hypokalemia, with a number of patients, around 4% of patients treated may develop hypokalemia. Edema-related events for retention of the sodium was not quite common. Sodium zirconium cyclosilicate should be administered at least 2 hours before or 2 hours after oral medication with clinically meaningful gastric pH dependent bioavailability. And this is the first part of my presentation. If we want to go to the questions now, it's okay. If we want to wait until I finish the second part, it's okay.
I think it is better, Professor Amir, to discuss some question if anyone have questions,
Okay.
because we will shift to another point completely different from the previously mentioned points related to hyperkalemia. Let me start by one question. First, I want to thank you very much for this illustrative, up-to-date lecture, Professor Amir, as usual. Regarding the sodium polystyrene sulfonate, we use it for several years, and I think if we add something like laxative medication, we didn't face any big problem. Why they try to find another medication to solve the problem of hyperkalemia? And despite it is very effective in management of hyperkalemia, except for the presence of constipation, which is really common with this medication. But if we add any laxative medication, the patient will respond well, and the constipation resolve completely, and the patient recover from hyperkalemia. But Amir, as you show us, there is several side effects. Starting even it has a side effect like constipation, which is common in the study which you discussed with us. Also, sodium zirconium is very, very expensive. What forced us to shift from sodium polystyrene sulfonate to something like sodium zirconium, which is available now in Egypt? Professor Amir, please.
I think the point of this shift, as we put in the first 3 slides of my presentation, they said that it is an old drug. Start using it from 1960. This is the first point. And they said that there is a lot of controlled trials to prove the efficacy. But from clinical point of view, I think it is an effective drug. The side effect, I think, is quite more common with SPS if compared with other new drugs. Mainly the side effect and intestinal proliferation and constipation. It was very harmful in this patient. This is the first point. The second point, that on my show of the slide, they said that in the maintenance period of the new medication, either Batirumir or Lokelma, the side effect start to disappear, and the constipation start to disappear, and other side effect may appear if compared with
Dr. Amir.
early emergency situation. And I think I got some clinical experience with the use of these drugs in emergency situations, or patient with a high degree of hyperkalemia, and they use it within the first 48 hours was quite effective. This is the cause they start to export these drugs and say that all the drugs are not quite common, effective, and the side effects are more common. This is the point, but it is a quite expensive drug.
Yes. Okay.
I will go now through the second part of my presentation, which is hyponatremia. And the new coming drugs for the treatment of hyponatremia, which is called aquaretic therapy, the newest addition in hyponatremia treatment. What is the rationale for using these new drugs for patients with hyponatremia? Actually, the appropriate method of treating hyponatremia and heart failure is by removing excess total body water. This is the aim treatment of or treating edema in patients with congestive heart failure. This objective of fluid restriction, or the aim is the objective of fluid restriction that decrease body water via insensible loss of water, but very ineffective and very slow. A better therapy would be blocking the process of urinary concentration, which originate from arginine vasopressin binding to V2 receptor in the kidney. This is the idea or rationale of aquaretic therapy. These are the different name of the medication in the Vaptan groups or aquaretic therapy, including different medications like Conviptam, Tolvaptam, Lexivaptam, and other medication. And these are the different human trials done on this medication, starting by Tolvaptan and Mosavaptan and other Vaptan trials. Let us start by Tolvaptan. Actually, Tolvaptan is a quite important drug in our renal practice. First of all, it was approved by USA FDA in February 19, 2009. It is a selective competitive vasopressin receptor 2 antagonist used to treat hyponatremia associated with congestive heart failure, cirrhosis, syndrome of inappropriate antidiuretic hormone. The most important point why we are stressing on Tolvaptan if compared with other drugs, Tolvaptan may be used in reduction of the size of cyst in patients with polycystic kidney disease, and this is another indication for Tolvaptan in patients with chronic kidney disease. And the studies say that arginine vasopressin has a role in the growth and enlargement of the kidney size in patients with polycystic kidney disease, and the use of Tolvaptan may reduce the size of the cyst, reduce the size of the kidney, and reduce the progression to chronic kidney disease. Unfortunately, this is not our point today or our issue of discussion today, so we will stress on Tolvaptan and management of hyponatremia. Mechanism of action: stimulate increased water excretion from the kidney. Blocking the V2 receptor has no effect on sodium or potassium excretion. It simply causes increased excretion of water without increased sodium or potassium excretion, avoiding the side effect of the diuretic. Therefore, Vaptans are electrolyte sparing, and it is more appropriate to kill their effect as equiresis or increase urinary water excretion rather than diuresis, which classically has been defined as increased urinary water and solute, particularly sodium and potassium excretion. What about mechanism of action? When taken orally in a dose of 15 to 60 milligram, it antagonizes the effect of vasopressin, cause increase in urine water excretion, and result in increased free water clearance, reduction in the urine osmolarity, and reduce and resulting in increase in sodium excretion and water loss. Urinary excretion of sodium and potassium, plasma potassium concentration are not significantly changing. The usual starting dose is 15 milligram. The dose may be increased to 30 milligram once daily, maximum dose 60 milligram. During initiation and titration, monitoring of the blood, monitoring of the change in serum electrolyte and volume to prevent overcorrection of serum sodium. Tolvaptan is contraindicated in patients with urgent need to raise serum sodium, inability of the patient to sense or appropriately respond to thirst, hypovolemia, hyponatremia, concomitant use of cyclooxygenase 3A inhibitors, and in patient or in anoric patient. What about the studies was done on tolvaptan? We will go through some study starting by SALT 1 and 2 study. Our study of the ascending level of tolvaptan in hyponatremia was multi-center randomized double-blind placebo-controlled trial. Number of patients around 450, hypervolemic or euvolemic hyponatremia resulting from heart failure cirrhosis compared with placebo. Number of all patients on oral tolvaptan was around 225, placebo the same number, approximately 223, and the dose titrated from 15 to 60 milligram daily. And this is the serum sodium level with tolvaptan and placebo at the start of the study. We'll go through the exclusion criteria: psychogenic polydipsia, post-operative condition, head trauma, hyponatremic condition associated with the use of medication, and clinically evident hypovolemic hyponatremia as it leads to marked reduction in the volume status of this group of the patient. And this study was evaluated at the baseline 8 hours after the first administration of the study drug, and on day 2, 3, 4, 11 until 37 days. Study drug was held after day 30, and the effect of the discontinuation of the study was assessed on day 37. The primary endpoint, the change in the average daily area under the curve for sodium potassium concentration from baseline to day 4 and from baseline to day 30. And this is the result of the study from the baseline to day 4 with rising in the serum potassium level in patient on tolvaptan if compared with placebo. From the baseline to day 30 was rising in the serum sodium level in patient with mild and marked hyponatremia in SALT 1 and SALT 2 study. As we see in this table in numbers, sodium level was elevated by 4 from the baseline to day 4 and to 6.2 from the follow-up period if compared with placebo 0.4 and 1.8. During maintenance phase, there is also elevation in the serum potassium level by significant number in the tolvaptan. And this is a diagram show the rising in serum sodium level compared with placebo in patient with marked hyponatremia in SALT 1 and SALT 2 study, and in patient with mild hyponatremia. In summary, patient received either tolvaptan or placebo at the starting dose of 15 milligram. The dose of tolvaptan or placebo was increased to 30 milligram if necessary. During the 7-day discontinuation and follow-up period, serum sodium concentration in patient treated with tolvaptan was increased compared to the placebo. In patient with euvolemic or hypervolemic hyponatremia, tolvaptan and oral vasopressin 2 receptor antagonist was effective in increasing serum sodium concentration at day 4 and day 30. Another study was extension study for SALT 1 and 2 trial called SALT Water trial. Oral tolvaptan is safe and effective in chronic hyponatremia, and this was the result on SALT 1 and 2 and in SALT Water trials with elevation of the serum sodium level above 135 if compared with placebo. And this is the analysis of the serum sodium level by visits during the long extended phase of SALT Water trial. And these are the comparison between serum sodium level in different subgroups of patients in patient with congestive heart failure, cirrhosis, SIAD, and other patients. In conclusion, prolonged administration of tolvaptan maintain increased serum sodium with an acceptable margin of safety. Effect of tolvaptan on dyspnea and relief from another study called Everest trial. And the conclusion, tolvaptan modestly improved dyspnea compared with the standard therapy alone, regardless if given early or relatively late after hospitalization, and also across major pre-specified subgroups. Another study called the Quest study, and the conclusion of the Quest, tolvaptan reduced volume overload and improve congestive symptom associated with heart failure by a potent water diuresis or aqueous. And thank you for your attention.
Thank you, Professor Amir. Really, you did a great effort, and thank you very much for this very good and illustrative lecture. To summarize, Professor Amir talked about hyperkalemia and the management of hyperkalemia with recent medication, also hyponatremia and new medication dealing with this problem. The first part of the talk was about hyperkalemia and management, and he talked about the sodium polystyrene sulfonate, patyromere, and the newly medication, the sodium zirconium cyclosilicate. And second part of the lecture, he talked about tolvaptan and how it is effective in management of hyponatremia, especially in congestive heart failure, cirrhosis, SIAD, and surprisingly managing and retarding progression of renal failure and size of the cyst in patients with polycystic kidney disease. Let me start my first question, Professor Amir, about the polycystic kidney disease and use of tolvaptan. Is something like that? I think it must be many studies about the management or retarding progression of chronic kidney disease in polycystic kidney disease. Did you read more about this topic?
Actually, I don't go in details through the study in polycystic kidney disease, Professor Yasser. I go only on the treatment for hyponatremia and hypervolemic or avolemic patient with congestive heart failure or other disorders. But the conclusion of the study in polycystic kidney disease, they said that it is quite effective in reducing the size of the cyst, size of the kidney, delaying the progression of chronic kidney disease.
Thank you very much.
I don't go through the details.
Because it is very important. We face many patients with this problem, and we can't do anything with them. But presence of tolvaptan to solve partially this problem or to reduce the progression of renal failure, it will be very nice. Now we open the discussion and the question.
Excuse me, Professor Yasser, Professor Amir, thank you for this very elegant talk, and thank you for your smart moderation of the meeting, Professor Yasser.
Thank you.
I have a comment that it's about the side effects of tolvaptan. Professor Amir, you said that these are acceptable side effects and acceptable profile of side effects. But
regarding the main side effect, Professor Yasser, with the prolonged use of tolvaptan may be hypernatremia. And
yes.
The other side effect, I didn't get a striking side effect. They said that mainly may be GIT side effect, but they stressing on the point of hypernatremia rather than other side effect.
But yes, and this is the main problem, I think, with their use in adult polycystic kidney disease, affection of sodium profile. And in hyponatremia, rapid correction usually is a problem that we can cannot accept the level of the correction. How much? The fear of rapid correction is the main issue with tolvaptan. As far as my knowledge, I think that it is the main limiting issue in treating tolvaptan and making it some steps back than its initiation and if the approval area in this century. Do you agree with me or?
In the United States of America, Professor Yasser, by the name of Samaska, but yes. I don't. It is not available in Egypt or other Arab countries. I'm not. I don't know whether it is available in other countries or one of our colleague attending the presentation with us familiar with the use of this medication.
Okay, Professor Amir, thank you.
We have question from Dr. Zainab. Dr. Amir بتسأل على use of tolvaptan in congestive heart failure in patients with pulmonary edema.
I think it will not be quite effective. Patient with pulmonary edema, we must interfere with this patient very rapidly, or the patient is going to die. It may be used during the follow-up period, but they don't use it in the patient with pulmonary edema, to my knowledge. Or they don't stress this presentation. Stable patient with congestive heart failure, volume overloaded, patient with cirrhosis. These are the main category of patient. But patient with pulmonary edema, from my clinical point of view, it will not be quite effective in this situation.
Okay.
Yes.
Another question. Which stage of adult polycystic kidney disease we can benefit from tolvaptan?
I don't go in depth for the use of tolvaptan in patient with adult polycystic kidney disease. So I don't know whether a stage may be used, the duration of treatment, and the result. And I'm not familiar with the use of this drug.
Okay, let us ask this question by another way. Can we use it in patient with chronic kidney disease stage 3 to 4, for example?
Why?
Is it safe?
I don't think so.
Is it effective at this stage?
We don't discuss the use on patient with chronic kidney disease, with late stage of chronic kidney disease. And I'm not familiar with the study, as I said before, study of tolvaptan in patient with polycystic kidney disease.
Okay, Dr. Yasser, have
we have Dr. Khaled Abu Zaid. We have Dr. Khaled Abu Zaid asking some questions, but with many abbreviations. Edema, NF, HF. So please, Dr. Khaled is with us.
Congestive heart failure, maybe.
Dr. Khaled, he used to ask his questions by himself. Please, he's unmuted already. Dr. Khaled, please.
السلام عليكم جميعا.
عليكم السلام ورحمة الله.
بسأل بس معلش الإديمة والكونجستيف هارت فيلير مع الاس زد سي اللي هو ان كومباريزون بالاذر انتي هايبر كاليميك ايجنت اللي هي already is not associated with edema and heart failure. Is it يعني safe to be used or it is associated with deterioration of heart failure and edema?
مع اليوز of new agent for hyperkalemia, Professor Khaled.
Yes.
Yes.
With the use of the Lokelma, they say that sodium retention is not quite common side effect. It may appear in about 2 to 4% of patients. So it is not quite common side effect, but it is reported.
It's reported and also associated. It makes some troublesoming of some patient.
Yeah,
especially most of our patients mainly have a congestive heart failure and the edema, like a nephrotic congestive heart failure population and like that. That's why if we have any other agent increasing or making some burden as regards the salt retention, salt and water retention, especially if it's used for treatment of other agents like potassium, it will be a burden for a patient, a burden for us for controlling edema on those populations.
Yeah.
I think it is something similar that we use sodium bicarbonate for delaying progression of chronic kidney disease and its issue with congestive heart failure, for example. Yes, salt and water retention, the same problem. But it is of concern, of course, with the use of the drug.
Yes. Second question, please, is I'm asking about for how long we have to use the Vaptans as a treatment of hyponatremia, because actually we don't have experience with Vaptans. We are reading and hearing about Vaptans since many years back in Europe, but actually we are not using in our countries for polycystic kidney disease, for hyponatremia, and so on. So hyponatremia, actually, I'm facing a lot of patients with a level of hyponatremia with reset osmostat, with very low level of sodium, and don't have any complaint. I think the problem mainly is related to the fluid retention also. That's why we are looking for some agent as making some sort of diuresis or acuresis water loss without salt loss. But actually, those population is tolerating this low level. I have one patient, his sodium, by the way, is 98 without any symptoms. Is a chronic patient. Really, I know it is it's so astonishing because the patient don't have any symptom with this level of. I think if I try to correct his sodium, I will kill him. I think the sodium correction is related to the symptoms, not related to the numbers.
But
that's why I don't have experience with victims, and I know I told you an extremes, but really we don't have experience for victims to talk about it.
I think this is a very low level to be left, Dr. Khalid, and
I'm sure, Dr. Yasser, but really, it's in practice. We have some patient, because actually the definition in the literature and in all references is hyponatremia is sodium below 135. That's the definition of hyponatremia. But actually, we have many patients with very low level of sodium without any symptoms. And all of us knows the only way of correction or only indication for correction of sodium is asymptomatic, is neurological disorder. That's the one who guide us to correct the hyponatremia, it's to correct the sodium level. If it is rapid, it's a mirror image correction. If it is rapid loss, it will be treated early. But in chronic hyponatremia, if the patient is asymptomatic and don't have water retention, and I think there is no need for intervention of those population, just to correct anti-failure measures. They're available in our countries, at least, anti-failure measures. And keep in mind the sodium to be accepted in a level not affecting the central manifestation, not associated with central manifestation. I don't know. That's my opinion. I don't know if this is right.
I think, yes, it's to be considered, of course, but I think this works with mild hyponatremia, mild levels, not severe levels, below 120. Symptoms here is important, of course, but in very severe levels, such the level you mentioned, I think it is difficult to be left. One good example of the usual in practice we meet for hyponatremia is the use of diuretics. This is the way of action of loop diuretics, is to excrete sodium and work like this. But usually it is plays within the level of mild hyponatremia. But 89 is a very, very low level, Dr. Khalid. I think it's very difficult to leave one like this.
You are totally right, but in practice, I have one patient, his sodium, hair sodium is an old age, about 90s, hair sodium is 89 without any symptom. I know it is unbelievable, it is unacceptable, but really it's already in practice.
Okay.
Sorry, my question. I will not. Did you have any experience as regards the use of hypertonic saline with diuretics plus albumin as a treatment of congestive heart failure and hyponatremia?
Hypertonic saline?
Hypertonic, 3% hypertonic saline plus loop diuretics plus serum albumin and aldactone as a potassium-sparing diuretics for correction of congestive heart failure and nephrotic syndrome in patients associated with hyponatremia.
مساء الخير، شكرا. مساء الخير، شكرا دكتور امير ودكتور ياسر. بس عندي كومنت لحضرتك دكتور خالد، هو ليه طب ما بنعملش ووتر ريستريكشن؟ يعني الحالات الكونجستيف هارت فيلير والحالات اللي فيها الراس سيستم اكتيفيشن، احنا في الحاله دي عيان عنده هارت فيلير بيشرب ميه كتير، نعمل ووتر ريستريكشن شويه، ليه هندي هايبرتونيك سلاين؟ بعدين حضرتك الرقم بتقوله زي ما الدكتور ياسر بيقول لحضرتك، ليه 98 ده رقم قليل جدا يعني. ده اكيد في CNS مانيفستيشن او اي حاجه، حتى لو العيان عنده يعني حاجه بسيطه، بس يعني مش لازم يكون اكيوت، ده حاجه كرونيك شويه، لكن رقم قليل جدا يعني مش هيتساب كده.
It's a fact والله يا دكتور. I know it's but really the patient don't have any central manifestation. Really we are in patient with congestive heart failure, we are starting by rest, avoid too much drinking of water, avoid salt and so on, so all of that, but actually refractory, resistant to diuretics, heart failure and the congestive heart failure and the nephrotic syndrome, we are using this one. And now in my centers and in my group, we are using this regimen. Up to this moment, we reach up to about 3,000 patients with يعني so excellent results with
Excuse me,
very
Dr.
rare, very rare hypotensive attack, very rare electrolyte imbalance, very rare renal impairment as a pre-renal azotemia or something like that. The diuretics, maybe the patient is getting a negative balance per day from 4 to 5 liters of water without any attack of hypotension. It's a big study, actually, have about 3,000 patients, and we will issue this one, inshallah, soon. And the hypertonic saline in combination with Lasix and albumin, plus other diuretics, such as a potassium-sparing diuretic, is associated with very effective management of congestive heart failure and nephrotic syndrome population, especially with hyponatremia.
Why
Let we wait, please, till the publication of this study, complicated study, Dr. Khalid, as it have many questions. You will have many questions and comments on this, why albumin and why hypertonic saline, and the place of extracellular volume, a state of extracellular volume, of course, and etc. Okay.
Sure, Dr. Yasser.
Sure,
I know there is
sure.
a lot of questions as regards these
Yes.
components and what is the effect of each one. And we have the answers for all, inshallah, in our.
Okay, waiting for this study to be published and have a very hot discussion and follow the very hot discussion regarding this very complicated issue. Professor Yasser?
Thank you, Professor.
We have many comments.
Yes.
We have many comments from Professor Hisham Al-Sayed, Professor Faisal Shaheen, Syed Khamis, please. Professor Yasser?
Any comment from Dr. Faisal, Dr. Saeed?
Yes,
Dr. Faisal, please.
Yes,
Okay.
Thank you, Yasser. Thank you very much. Excellent talk. But let us please, tolvaptan, it can be used not in every hyponatremic cases, because usually we use it in SIADA and congestive heart failure, and it is a very expensive drug. One tablet, I think it's around $15 one tablet only. So it is very expensive. We use it in a patient only in 3 conditions. Polycystic, even we don't use it till now, but we use it for any hyponatremia which is not responding. As you know, it is simply someone who is hyponatremia presented, you will differentiate either it is dilutional or it is mineralocorticoid deficiency, or it is, you have to differentiate and you treat the cause. So if someone comes with diarrhea, with vomiting, you treat all of this and correct the sodium. And as Khalid mentioned, this is the management according to the level of the sodium. We will manage by hypertonic saline in the start, or 3%, and we don't increase the sodium only between 8 and 10 millimolar within 24 hours. So there is a criteria to use tolvaptan, not in every single case. There's only few indications for it, because again, as I said, it's very expensive drug. We use it, we don't have side effect if we chose the proper patients and give it to the proper diagnosis. Thank you.
And
I think, Professor, yes, during my presentation, I stress on the type of patient used on the study on tolvaptan. Mainly patient with congestive heart failure, patient with liver cirrhosis, patient with syndrome of inappropriate antidiuretic hormone. These are the groups of patients used in most of the study of tolvaptan.
Yes.
Totally agree with you, Professor Amir, and thank you, Professor Faisal, for your comment, which highlighted one practical point for the use of tolvaptan. And also,
yes, for Professor Faisal.
Yes, sir.
Yes.
Did you try these drugs in patients with polycystic kidney disease?
Yes, well, it is known that it can delay the progression of polycystic kidney disease, but because it is very expensive, you know, if we give it to one patient and the dose, high dose between 15 to 60 milligram per day, the tablet, as I mentioned, $15. So this means that I'm going to treat the patient by 1 million real per year, which is a lot. I will let him to go to end the stage and they will not do that. So I don't know. Some people request, some patients come and say there is a drug which can delay the progression of kidney disease. I give him the name. I said, this is, if you want, it is available and you can start to take it. But the insurance company is not covering this till now. If they cover it, probably we can go ahead and use it in polycystic. We have too many patients need such a drug.
Thank you, Professor.
I think drinking plenty of water could be a better alternative for something like this in delaying the progression of kidney disease. Did we have a specific session for adult polycystic kidney disease later on and have this very nice discussion in its place? But Dr. Hisham Al-Sayed, Professor Hisham Al-Sayed wants to comment.
Good evening, all. I will try to clear the smoke because we have. I will try to clear the smoke and to be clarified in some points of hot topics you just described. One of them I would like to share to read the New England Journal of Medicine published this year about tolvaptan versus high water, as exactly as you say, Professor Yasser, in polycystic kidney disease. And the title was very exciting, saying that can additional water a day keep the cyst away? This is, I think this is a very short notes about the high water intake for the progression of polycystic kidney disease. As Professor Faisal said, it's very, 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 very expensive and non-usable in clinical practice. Considering the hyponatremia, yes, you can use it in very selected cases. Our practice in hyponatremia and heart failure is definitely water restriction, number 1 and 2 and 3. And you can go to hypertonic saline very rarely in patients with the hypervolemia. Another comment, I would like to flash back the hyperkalemia. And I think this is one of the great message that we have to highlight for all colleagues, is the hyperkalemia and potassium chelators or like Lokelma and other in patients on hemodialysis. This strategy is not common in between practice in many countries. Some countries in the, like France and the others are using more than other countries. And I think one of the strategies is to implement the potassium chelators or potassium resins, whatever the name, in patients on dialysis, in between the dialysis, especially for patients with risk of sudden cardiac death or patient with arrhythmia, because the resting potential of the cells is very excitable during dialysis, and the gap between hyper and hypokalemia in dialysis patient is very small. The safety profile to reach potassium in dialysis patient pre-dialysis is between 4.5 and 5.5. So if you have even potassium more than 5.5, you can carry a risk. Thanks again, and I would like to thank Professor Amir and Professor Yasser for his talk, and we can clarify that this point, please.
Thank you, Professor Hisham. You cleared the smoke already. Thank you very much.
Thank you.
We wait for studying the tolvaptan in retarding progression of chronic kidney disease maybe later, because it is, as Professor Faisal said, it's very, very expensive. 1 year expend about 1 million riyal, so it is very, very expensive.
And still the result is questionable. Just taking a higher amount of water can give the same effect.
Yeah, okay. Any question?
Yes, we have some questions on the chat, but Rami, please. Dr. Rami,
yes.
can you help us with the skipping questions from the chat? As I cannot get them.
There is a question, Professor Amir, about the calcium containing and how it differs from the sodium containing for medication in management of hyperkalemia, calcium containing and sodium containing resonium. The difference between calcium containing and sodium containing. This is a question for you. But we didn't talk about calcium containing or any calcium containing resonium, Rami. This is Rami question. Rami, please clarify what's your question.
السلام عليكم. الأول شكرا دكتور أمير على المحاضرة العظيمة كالعادة. هو بس في الماركت في تو تايبس اوف بوتاسيوم اكسشينج ريزن، هو في الصوديوم كونتيننج وفي الكالسيوم كونتيننج. ف is there any prevalence of use this one over this one or the same?
I think it's the same, Rami.
What is the name of calcium containing, Rami? I think it is the calcium rhizonium in Saudi Arabia.
Yes, in Egypt we have calcium containing. Yes.
Sulfostrate, we have sulfostrate and which is calcium paste, and the sodium paste is xenocatin, and in Saudi Arabia is calcium sulfostrate is by the name, I think, calcium sulfostrate, and some Arab, yes. But the difference, if you allowed me, Professor Amir, just to highlight that the condition is not like calcium or sodium. The mechanism is beyond the salt included. For sure, sodium will do salt retention. Calcium can induce more necrosis of the colon. But please refer back to the mechanism of two options we have here. The molecule of Lokelma differ for their affinity even for potassium. Second point, just to highlight why this polystyrene or calcium rhizonium or whatever works on colon mainly. If you review back against the intestinal fluids, you find that the intestinal fluid potassium content is above 30 millimole per liter, while in the stomach it's about 10-20, and in saliva it's above 20. So its affinity in the colon is high, its action in the colon is more high, and so calcium can induce more necrosis. If you have to choice, I would choose the sodium zirconium. Second choice will be the calcium. If the payments, because it's expensive, the Lokelma. And the third choice for sure will be the sodium paste on that.
Excuse me, the other point, Professor Hisham, that we are to consider, of course, the other salt content for conditions such as if there is volume overload or severe hypertension, and sodium containing,
we have
and hypercalcemia, and hypercalcemia with calcium containing should be avoided.
And even old people who have the possibility of necrosis of the colon, or perforation or ischemic colitis, it's a worry to use calcium in those patients. So you have to mind about calcium paste or sodium paste also, or zirconium. It's the best is the zirconium up till now.
So it is better to individualize this medication for each patient. Old age, we have not to use calcium. Patient with hypercalcemia, not use calcium containing potassium exchange resin. Patient with congestive heart failure and sodium retention, we have to avoid sodium containing potassium exchange resin. Any question more?
Yes, just to highlight, Professor Yasser, our team I described in this last dialysis conference 1 week ago is my team is patients are not twins, so you have to individualize everything.
Yeah. Yes.
Okay. Professor Yasser, Professor Amir, let we welcome Professor Saeed Khamis again on his comeback. This is the first meeting to attend after his health trouble. Professor Saeed.
Thank you, Professor Yasser. Thank you,
Professor Saeed.
ألف شكر. Thank you so much, Professor Yasser, Professor Amir, Professor Yasser, Professor Hisham, all attendees. Actually, it was a very nice topic to be discussed tonight, and it needs at least 3-4 hours to discuss. But anyway, just I have 2 comments, if you allow me. Number one, regarding the one of the side effects of this tolvaptan, despite it is written that we can use it in cirrhotic patients with hyponatremia because it's hypervolemic hyponatremia. So we should be careful in the decompensated cirrhotic patient because it can lead to rupture of the esophageal varices and lead to hematemesis in many patients. So it can lead to upper GI bleeding. This tolvaptan in advanced decompensated chronic liver disease. That's number one. Number two, regarding the cost of this Lokelma, it may be it is like a joke, but I will tell, if this patient has the ability to pay for this leukemia, I think we can put him on nocturnal hemodialysis, home dialysis. It will be better regarding mortality and morbidity. Number 3, regarding the point raised by Professor Khalid Abu Zaid, yes, it is there, this hypertonic saline as a modality or add-on therapy to this loop diuretics. If there is a resistance to loop diuretics, to decongest a patient with acute heart failure or chronic heart failure, even without hyponatremia. I mean, ionatremic patient. So we can add 50 milliliter of 3%, 3 times daily, IV. In a limited or small studies, it is there. But up till now, there is no randomized studies investigated this point. Regarding the add-on therapy, last week in this what's called the European Society of Cardiology meeting, and also published in this issue of New England Journal of Medicine, what's called the ADVOR study, or acetazolamide in decompensated heart failure with volume overload trial. It was about 500 patients from 30 hospitals in Belgium, and they investigated the add-on therapy to the loop diuretics, I mean resistant heart failure to loop diuretics, and they found that acetazolamide, this old drug, the Diamox, can be very effective in decongesting the patient as an add-on therapy to to this loop diuretics. So this add-on therapy is there, and we should keep in mind, because it is of great interest to the cardiologist also. Thank you so much.
Thank you, Professor Saeed, for the comment. Dr. Yasser, if there is any question?
From Dr. Khalid Abu Zaid, asking about how can we deal with avoid rapid correction of low sodium level in cases of urgent hemodialysis. And Professor Amir and Professor Hisham can help us also.
Type of patient, Professor Yasser?
In patient with on regular hemodialysis, Amir.
What's the why is hyponatremic? Is the volume overloaded?
Patient is hyponatremia with dialysis. He is asking
how we can correct that.
This is the question. Yes, this is a question for Professor Hisham.
Sorry, my question for Professor Hisham Saeed, please. We are facing some patient with very low level of sodium in need for urgent hemodialysis, and as you know, they will be corrected very rapidly with dialysis. So the sodium level will be corrected more than 20 degrees, more than 25 degrees in a very few hours.
Yes,
but the patient has this chronic hyponatremia. How can we protect those group from rapid correction of sodium in a hemodialysis session?
Okay, thank you for highlighting this very important point I discussed with Professor Bernard Cano 1 year ago on this issue on dialysis in patients with hyponatremia. One of the things we have to define that in a review by Kalantar Zada, probably a few years ago, that hyponatremia has a U-shaped mortality in patients on dialysis. So if you have a hyponatremia, you will have a high mortality, and we have hypernatremia, you have as well mortality. Coming back to your question, I believe that hyponatremia should be considered carefully in patients, especially in patients with acute kidney injury, needing hemodialysis intervention, either the intermittent hemodialysis or prolonged intermittent kidney replacement therapy. Hyponatremia mainly is due to hypervolemia, so you don't worry about the higher sodium we will gain during dialysis unless you are doing more ultrafiltration. But basically, and clinically, if you apply that, the equation of around 10 higher of serum sodium and more prolonged dialysis, you can avoid the massive sodium load on the patient and subsequently rapid correction. So if the patient, for example, is coming with serum sodium 120 and you have to do dialysis for acute kidney injury, and the patient is hypervolemic, you expect that serum sodium is not so much below that number because of hypervolemia, and you put the ultrafiltration capacity and the conductivity meter around 10 above the actual patient hypernatremia. But there is no rule of thumb in this way.
Okay, I think also that sled could be an option also.
Yes, prolong it, yes.
Prolong it. Low efficiency dialysis is could be an option, or in addition to
you have to do
the level of serum sodium dialysate and serum sodium together.
It's a prolonged intermittent renal replacement therapy, meaning that you have to include either SLED or even 12 hours of CRRT.
Okay. Okay, Professor Yasser, no more questions on the chat and no more comments.
Okay.
Can we close? I will.
Okay. Thank you for everybody, and we enjoyed sharing this day. It was very fruitful, and I really enjoyed joining my colleague and professor. Thank you, Professor Amir. Thank you, Professor Yasser Abdelhamid. Thank you, Dr. Hisham Said. Stop emotion, please, Dr. Hisham Said. Stop emotion.
Okay.
Thank you for everyone. Share with us. Professor Dr. Saeed Khamis, Professor Dr. Faisal Shaheen, and I'm afraid to forget anyone. Thank you, everybody. I will let Professor Yasser Abdelhamid to close this session. Fadal, Dr. Yasser.
Thank you, Professor Amir, for your smart, elegant, and comprehensive to the point lecture. Thank you, Professor Yasser, for moderating this session in this practical and smart way, and leaving a good space for this heavy discussion. Thank you all, Professor, who shared us in this very fruitful, heavy discussion today. And as I expected to have a strong one, and this was even more than I expected. Thank you all, and excuse me to close this fruitful night and announce about the coming session, which will be a clinical nephrology forum presented by the National Urology and Nephrology Institute next Wednesday, inshallah. Excuse me to close. تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
عليكم السلام.